The postpartum period is the highest risk phase for maternal mortality, with postpartum hemorrhage currently ranking as the fourth leading cause of pregnancy-related deaths in the United States. A patient who appears stable can progress to hypovolemic shock or sepsis within minutes. This rapid, unexpected decline occurs because the expected physiological changes of a normal pregnancy often hide the early signs of a crisis. To manage these risks, we categorize clinical data into three high-priority buckets: hemorrhage and shock, coagulopathies and VTE, and postpartum infections. This triage matrix separates expected physiological recovery from the critical indicators of an emergency. By filtering out normal transitions, we isolate the specific assessment findings that require immediate clinical intervention. Clinically, postpartum hemorrhage is defined as a cumulative blood loss of 1,000 milliliters or more, or any amount of bleeding accompanied by signs of hypovolemia within the first 24 hours of birth. To identify the bleeding source, the medical team utilizes the 4 Ts algorithm: tone, trauma, tissue, and thrombin. Tone, specifically uterine atony, is the primary cause. It occurs when the uterine myometrium fails to contract and compress the spiral arteries, preventing hemostasis. During a physical exam, expected recovery shows a firm midline fundus. Concerning signs of atony include a boggy uterus, or a fundus deviated to the side by a distended bladder. There is a critical exception within this algorithm. If a patient presents with heavy, bright red bleeding while the fundus remains firm and midline, the nurse must suspect a genital tract laceration or a hematoma rather than atony. Visual estimation of blood loss is unreliable and frequently underestimates the actual volume lost. Protocols now require quantitative blood loss, or QBL, where all blood-soaked items are weighed, with 1 gram of weight equaling 1 milliliter of blood. If the uterus is boggy, nursing priorities include beginning fundal massage immediately, calling for assistance, emptying the patient's bladder, and preparing for medication administration. Oxytocin is the first-line medication used to stimulate uterine contractions. While effective, the nurse must monitor the patient for signs of water intoxication, a known adverse effect. For second-line medications, history dictates the choice. Methylorganovine, or methergine, is contraindicated in hypertension, as it can trigger a massive surge in blood pressure. Similarly, carboprostromethamine, or hamabate, must never be administered to asthma patients due to severe bronchospasm risks. Misoprostol may also be used off-label. This prostaglandin forces the uterus into rapid contraction. Mastering the 4 Ts requires recognizing when tone has failed and responding with immediate mechanical intervention paired with patient-specific medications. Physiological hypervolemia of pregnancy can mask a crisis. As blood volume drops during hemorrhage, the blood pressure line remains stubbornly stable. Due to this expanded volume, a patient can lose over 1,000 milliliters of blood before classic tachycardia or hypotension appear. To catch decompensation earlier, the nurse must monitor for subtler signs of shock, including delayed capillary refill, excessive thirst, and sudden restlessness or anxiety. The shock index is a more predictive stability indicator than blood pressure alone. It's calculated by dividing heart rate by systolic blood pressure. A shock index value greater than 1.0 is a critical threshold, signifying moderate to severe shock requiring a rapid response team. We also monitor thrombin issues. Coagulopathies interfere with the body's ability to form clots, which significantly increases the risk of a severe hemorrhage. Immune thrombocytopenic purpura, or ITP, is an autoimmune disorder where the body destroys its own platelets. Management typically involves oral corticosteroids or intravenous immunoglobulin to stabilize platelet counts. Von Willebrand disease is a hereditary clotting deficiency. During the postpartum period, these patients may require cryoprecipitate or specific factor replacements to prevent or treat bleeding. Relying on a drop in blood pressure is a clinical trap. Protecting the patient requires tracking exact blood loss and using the shock index to detect instability before the cardiovascular system fails. Pregnancy increases clotting factors like fibrinogen, creating a hypercoagulable state. Combined with venous stasis from the growing uterus, the risk for blood clots increases significantly. Half of all pregnancy-related venous thromboembolisms occur postpartum. Additionally, systemic infections and sepsis account for over 14%. For wound infections at a cesarean or episiotomy site, we use the RETA mnemonic to assess the area: redness, edema, ecchymosis, drainage, and approximation. In the breast, we must distinguish between the bilateral fullness of engorgement and the unilateral redness and heat associated with mastitis. Mastitis is assessed using the FAST mnemonic: fever, abnormal milk appearance, swelling or a salty flavor to the milk, and tenderness. The intervention for mastitis requires the patient to continue breastfeeding or pumping on the affected side to clear the milk duct and resolve the infection. Because most expected recovery symptoms are symmetrical, any unilateral pain, swelling, or heat represents a systemic threat that must be addressed immediately. To summarize the clinical priorities, rule number 1, if the uterus is boggy, fundal massage is the first action. Rule 2, never give methergine to a patient with high blood pressure, and never give carboprost to a patient with asthma. Rule 3, trust quantitative blood loss and the shock index over standard vital signs. Rule 4, if the uterus is firm and midline, but bright red bleeding persists, assess for a laceration. And Rule 5, unilateral leg or breast symptoms are critical danger signs, not normal recovery. Mastering this prioritization matrix allows the nurse to distinguish expected findings from life-threatening complications. In high-stakes postpartum care, these distinctions are what define the window for successful clinical intervention.